Hello, I'm Lauren Haldeman, Editor-in-Chief of the Journal of Nutrition Education and Behavior, where we are advancing research, practice, and policy. And each month, we select an article to feature as a press release with an accompanying podcast. Today's podcast article can be read in full at www.jneb.org for free for the next 3 months. And today I'm really happy to be speaking with Brandon Stroud, who is the corresponding author for the article titled Impact of Food Literacy Education on Rural Uninsured Patients with Diabetes. And I'm really glad to have you with us today, Brandon. Can you tell us a little bit about yourself?
Yeah, thank you, Dr. Haldeman. I'm definitely excited to talk to you today and give you a little bit of an overview of this article. So a little bit about myself. I'm currently a teaching instructor at East Carolina University. I teach in our Department of Health Education and Promotion, primarily public health courses for undergraduates. And I'm also currently pursuing my PhD in nutrition science at the University of North Carolina at Greensboro. And prior to that, completed my master's of public health, and I am a registered dietitian as well as a certified health education specialist. So this is kind of going into some of the work that I've been doing over the last about 5 years or so. So I'm really excited to be able to talk to you about this today.
Well, we're excited to have you. So thanks very much for that. So let's get right to it. Can you give us a little bit of an overview of the paper, including what you did, why you did it, and some of those results?
Yeah, so I think I want to start off just by giving everybody a little bit more context, maybe that doesn't have as much around food as medicine programming. So I know this is an ever expanding area of research and practice right now, especially as it relates to nutrition education. And commonly what you see in food as medicine programs is maybe there's some sort of education being provided, but we have very comprehensive education that's being provided alongside our produce prescription. And so we know that it's not just the food access that is going to get people to improve their diet quality, to have those long-term behaviors. So we developed a 20-week intervention that includes 9 group classes that are very focused on skill building. So we have nutrition education, cooking demonstrations, diabetes-focused education. Participants receive a produce prescription every single time they come to those classes of a variety of produce, usually about 3 to 5 pounds. And they also get one-on-one behavioral support as well. So it's kind of these layered approaches that we utilize to really try to maximize diabetes self-management. And we enrolled roughly 150 rural adults with diabetes, and our intervention aligned food literacy focused education in the group classes with a validated tool to assess it. So really the main things that we were focusing on with this were meal planning, shopping, budgeting, label reading, consumer awareness, and kind of like nutrition resourcefulness. So like an individual's ability to be able to repurpose meals and do different things like that. And another component that I really want to highlight is also the integration of the health belief model. And so that, along with the socioecological model, really informed the foundation of this program. And there are some really critical things that we're addressing with this and trying to improve people's not only food access, but also their skills and their capabilities to be able to truly manage their diabetes and their glycemic control.
Great. Thanks. You want to talk a little bit about some of your findings?
Yes. So largely what we looked to examine first was the intervention effective? And so we wanted to look at, we have a score and protocol that we use on the Lavelle tool that's a food skills confidence assessment score. And we saw that there were significant improvements from about 89 on that scale to 101. So they were significant across all groups. And then we did kind of an exploratory subgroup analysis outside of that to see, were there particular racial or ethnic groups that experienced the intervention differently, or were they coming into the intervention at a different set point? And so what we really noticed from that was, yes, there were improvements across all groups, but our Hispanic participants in particular had lower pre and post scores compared to our African American and our white participants. And we had roughly even sample sizes. There were about 30-ish participants per group, so those did kind of align. And we really saw that even though everyone was significantly improving, there's probably some areas that could be addressed, especially with culturally tailoring for our Hispanic population, because they were just coming into the intervention with such lower food literacy skills than our other groups.
Thanks. This was a really excellent example of how you integrate theory into intervention and tying that to the activities of the intervention. So congratulations to you and your team for doing such a great job on that. You mentioned that you saw some differences among racial and ethnic groups, and particularly in the paper you talk about the food literacy outcomes. And then you also suggested that these are things that we need to pay attention. So why or what do these findings really suggest about the need for culturally tailored food literacy interventions?
Yeah, so that's a really great question. And I really feel like these findings suggest that food literacy interventions can't just be treated as one size fits all. And I think that's something that we have been saying in nutrition education interventions for years. I think food literacy is an ever emerging concept. More people are getting interested in it, and how it relates to health literacy, and just with the chronic disease epidemic, how crucial it could be to potentially mediating some of these outcomes that we see with glycemic control and hypertension and other things like that. So the differences in the outcomes across the racial and the ethnic groups, they may reflect some variations in a bunch of different things. Maybe their prior food related experiences, like who is actually teaching them in the household, or do they have anyone that's teaching them in the household any of those skills? Their cultural food practices, their access to affordable foods, preferred foods, just the language barriers. That's one thing that we didn't necessarily assess was, the majority of our participants, they are of Mexican descent, but we did not assess whether or not the questionnaire was culturally relevant to them or not. So those were some of the things that came up as questions when we were kind of looking at this analysis: is how is this intervention affecting them? And more than likely, we need to have a second intervention that's just for our Hispanic population. Here in Eastern North Carolina, culturally, there are some differences between African American and white participants, but they're not as stark as you would see in a Hispanic participant versus an African American or a white. So I think that was something that was also important as well. And so taking kind of all this together, this kind of highlights just the importance of cultural tailoring, acknowledging that there are diverse food traditions, there are different household roles, different shopping patterns. And there are so many different barriers to healthy eating that look different across everybody's environment. So tailoring interventions in this way can potentially improve their relevance, their engagement, maybe even the skill uptake, and hopefully long-term dietary behaviors, and just making things more equitable and effective across different populations.
Excellent points, and a lot to consider when you're working with some of these groups. So, the journal has really been trying to focus on food literacy. And again, this is another reason why I chose this paper. So if you think about it from the health systems perspective or a nutrition educator's perspective, what lessons from this program could help these groups to incorporate more food literacy education into their programs that serve limited, resourced, or rural populations with diabetes?
Yeah, that's a great question as well. So I think one key lesson from this program is that food literacy education is most useful when it's practical, when it's accessible, and when it's grounded in the realities of the participants' lives. You have to take into consideration their actual constraints. And so for resource limited or rural patients with diabetes, this means focusing on specific skills that are going to be relevant for them. So one of the things that we highlighted in one of the tables is we're not just using this food literacy education assessment tool to assess if there are changes based on nutrition education that's just generalized nutrition education, right? We have nutrition education that aligns with every single concept that is in that assessment tool and is also grounded in the health belief model. And so I think that intentionality that nutrition educators can bring to the table. I think when you think of cooperative extension and some of the things that they already do in their outreach, there's genuine and good alignment with that and some of these healthcare systems that are starting to move into this more as food as medicine programming, especially here in North Carolina. I know Blue Cross Blue Shield has gotten even more interested in some of the medically tailored meal pilots and different things like that, and finding ways that we can have natural intersection across systems that already exist, I think is most crucial. And ensuring that the education we're providing is addressing the biggest barriers. So commonly for us, those come down to availability of foods, transportation, cost, time. And so just ways that we address those specifically within our intervention was, okay, transportation is an issue. Let's find a centralized location within this community that's a trusted community partner. And so that's typically a local church in our rural areas where people feel like they're safe to go to and it's not that far for them to travel to. And then we're providing them with education and trying to get them to increase their fruit and vegetable consumption and also directly providing those fruits and vegetables in those classes. So we're trying to make the intervention a one-stop shop of we're going to provide you with the knowledge, the skills, but also the access to the resources and really try to check every single box that we possibly can to make the healthy choice the easy choice at the end of the day. And I think that is what we as practitioners and researchers should be trying to figure out is what is the easiest way for us to address all these barriers that we typically see. And lastly, I'll kind of just say, so health systems and nutrition educators can also benefit from emphasizing some of these culturally relevant examples. So simple take-home strategies, hands-on learning opportunities, things that are building confidence and self-efficacy in the classroom, I think can easily be taken home as well. And that's the biggest takeaway, I think, from this.
That makes a lot of sense. And you've given us a lot to think about in terms of how can we take these findings and apply them in a variety of settings. So thanks very much for that. And thank you very much, Brandon, for spending this time with me talking about your important research. Is there anything else you'd like to mention?
I think the only other thing I'd like to mention is I would like to thank my co-authors. Dr. Lauren Sastry is the PI for the Fresh Start program, and her and I have worked together for the last 6 years. I could not do this work without her and her guidance. So she has been wonderful to work with. And then Raven Breinholt is currently our assistant director and recently finished her MPH. And she was the main one doing a lot of the groundwork on this paper. So definitely want to thank her as well. And then also our funders. So the Duke Endowment and the ECU Health Foundation, want to say a big thank you to them as well. We're very grateful. And for all of our patients and the North Carolina Association of Free and Charitable Clinics that we work with, they do just such a wonderful job at addressing access to care across all of North Carolina, and they're kind of our state branch of the National Association of Free and Charitable Clinics. We couldn't do this work without them. So that's all I got to say.
Okay, well, thanks so much. And to all of our listeners, remember you can read this article in full at www.jneb.org for free for the next 3 months.